Welcome everyone to the Thursday conference of the Department of Medical Informatics and Clinical Epidemiology at Oregon Health and Science University. We have this conference every Thursday and occasionally at other times when it needs to be done then. And we like to have a wide variety of presentations. And we also even before the pandemic, we're broadcasting them and recording them, and we continue to do that. Obviously now in the pandemic, we are doing these remotely, virtually. So it gives me a great pleasure today to welcome Dale Sanders, who is someone that I've gotten to know actually where else over social media. And it turns out we have a lot of common interests, both in informatics and beyond. He and I have been chatting over the last few months. He is very passionate about clinical data, as are many people in our department, and kicking around some ideas. And he wanted to kind of put those ideas together more formally. And so I invited him to come speak to our conference with the goal that he give us a presentation, and we will give him feedback, constructive but cordial, as we always are. And he will hopefully find it useful to get our feedback and continue these conversations on a larger scale. Dale is currently an executive partner with Ardon Equity, but has spent a lot of time in the last decade or so working for the company Health Catalyst, which many of you know about. It's a data analytics company in the healthcare space. He started out as Senior Vice President for Strategy, became Chief Technology Officer, and stepped back from that role last year, now as a Senior Advisor. He's also worked for the Advisory Board Company. He's had experience in the military. He's been in many different places, and I could go on and on, but I don't want to take away time from his talk. His formal education has a bachelor's degree in chemistry and biology from Fort Lewis College, also did some study at the U.S. Air Force Institute of Technology. And again, if Dale, you wish to add anything else about your background you think would be informative, I'll let you add it, because I could literally spend the whole hour introducing you. But I think probably most of us want to hear your talk. So I will turn it over to you. As always, people can feel free to type questions in the chat. When Dale's done talking, you can unmute and talk to him. We do encourage people to keep their video on unless they're eating lunch, which happens at this hour, including myself. But hopefully you'll be engaged with the talk. So I will turn it over to him.
Thanks very much, Bill. I appreciate you sponsoring this venue for me. This is a topic I've been evangelizing for a while, and this audience is the first one to see sort of my current thoughts about it. And I'm looking for criticisms as much as I am compliments, and some validation or invalidation of the assertions that I have here. So let me share my screen and we will dive in. I'm assuming everyone can see that. Okay, so as the title was indicated during the invite, this is all about the evolution of the EHR and reducing clinician data entry burden while improving the state of data that we need in the industry. There are three parts to the discussion today. Part one is I want to share with you about why I care about this. Part two is the assertions and the evidence that support those assertions. And then part three is my thoughts about how to approach solving the problems described in those assertions. Here's the usual disclosures and affiliations, and I try very hard to never let any of these influence what I believe to be the honest truth. And Bill mention some of those. I'm a board member for a company called HealthTree, executive partner at Ardent Equity, senior advisor at Health Catalyst. I'm a limited partner at Foresight Capital that invests in healthcare related technology, senior advisor to IMO, which you folks probably know. And I'm a senior advisor at the National Institute for Civil Discourse and Common Sense American. There'll be a poll at the conclusion of the discussion today. And I'd like for you to think about this during the course of the discussion. On a scale of 5, I'd love to hear whether you strongly disagree or strongly agree with the following. The burden of EHR data entry to satisfy quality measures and reimbursement models is contributing to physician burnout. Data quality, that is complete, valid, and current data in EHRs, meets the needs of patient-specific care, population health, and clinical research. And finally, the U.S. needs a national, federally convened strategy to reduce the EHR data entry burden on clinicians, while at the same time improving the quality of EHR data that is collected and shared. Okay, think about those, and then I'll ask for some formal data from all of you at the end of the poll, assuming that Lauren can get the poll working. We're not quite sure. Okay, so part 1 is, why am I advocating this, and why the heck is Dale Sanders doing this, as opposed to someone like, Bill Hirsch or Nicole Weiskopf that have done research and lots of publications in this field. Fundamentally, the first thing is I believe that our digital understanding of patients is poor, and I use this graphic to share that as a metaphor. This is my life on the left. And on the right is healthcare's digital view of my life. And we have to do a better job as an industry and as professionals to round out the precision and the granularity of these views of patients and their true lives. I would also say we can't achieve precision medicine without precision data. The potential of AI in healthcare will never be realized if we don't change the way we're using EHRs. And I borrowed Gartner's hype cycle on the right there to show that we will stay here in the trough of disillusionment if we don't do something to improve the depth and breadth of data and the quality of data that we're collecting about patients. I have a genuine, sincere empathy for doctors and nurses. We burden them with collection of data that has questionable value to their professional calling. Then we strip them of their autonomy by measuring their performance with that same questionable data. And I would ask all of you, all of us that are neither a physician nor a nurse at this time, would you change your career to be in their shoes at this time in history? And I don't think there are many of us that would. And so we have to change that. And physician burnout, clinician burnout is a big reason that I'm interested in solving this problem around data entry in the EHRs. My personality is just naturally, inherently fascinated with finding the ground truth in any setting. My life motto is find the truth, tell the truth, and face the truth. We are a long way from an understanding of ground truth about patients and their health. So inherently, this is just a fascinating topic for me to get to that intersection between our beliefs and truths and expose knowledge. Bill talked a little bit about my career, 37 years so far. Hopefully that keeps going for a while. And it's all been about data and optimal decision-making. Before healthcare, I was an Air Force officer specializing in nuclear warfare command center operations. At TRW, a big space and defense contractor, I worked for NSA in the nuclear threat reduction space. And at Intel, I built their first data warehouse that managed and helped them optimize their supply chain and fabrication processes. I made the jump to healthcare, landed at Intermountain, where I was executive director of medical informatics at LDS Hospital and the largest region at LDS. I'm quietly very proud of that role. I was the only non-MD, non-PhD to ever hold that position. It was a big honor for me. Then I went on to Northwestern, I went to the Cayman Islands, went to Health Catalyst, now at Ardent Equity, where we invest in data and software companies. So I've got a pretty good view of what data and optimal decision-making is all about, and especially in healthcare for the last 20 or 25 years. And finally, why do I care about this? And my wife. She's a mathematician, statistician, and a data scientist in healthcare. And she's never far away from telling me that your fancy schmancy data warehouses are full of crappy data. And so there's full truth, or half joking full truth to that comment that she reminds me of. I want to acknowledge that Mickey Tripathi and I were collaborating on this slide deck months ago. Very happy and pleased to know that Mickey is now leading ONC, and so may be in a position to further the agenda that we're talking about here today. Sarah McGinty London, who is at Centene, a very large payer in the managed care space, is now my collaborative partner. It's super important, I think, that payers be engaged in this messaging and in the changes are ahead, because economics drive a lot of the reasons that we're collecting the data that we are right now. So money talks, and we need the insurance companies to get on board with data quality and reducing physician burden. I want to emphasize too that it's not the EHR's fault, right? I've been around EHRs just like all of you, Cerner, Epic, I mean, the list is long. Could the user interface of EHRs be better? Sure, of course. But the bigger problem is how we're using the EHR, and especially the data entry burden of quality measures associated with billing and reimbursement. Okay, part 2, my 4 assertions. Number 1, we're burning out our clinicians with data entry. The personal and professional burden of data entry in EHRs is contributing to physician burnout and job dissatisfaction, and distracts from effective care through the patient-clinician relationship. That's assertion 1. Assertion number 2, we're using the wrong data. The data that clinicians are required to collect reflects too much emphasis on reimbursement, billing, and defensive medicine, and not enough emphasis on situational awareness, hypothesis generation, and intervention and outcomes assessment. Said otherwise, population health, precision medicine, and clinical research should be the driving factors behind the data that we choose to collect in an EHR. We can figure out how to achieve billing and reimbursement and satisfy the lawyers in defensive medicine. We can figure that all out as a byproduct of focusing our data strategies on population health, precision medicine, and clinical research. Assertion number 3, we need to change our quality measure strategy. Quality measures of questionable clinical value are a major contributor to the data entry burden. Our national quality measure strategy must be adjusted to reduce the number and complexity of process-oriented quality measures and shift to emphasize the reduction of low-value care. So think about that, because I'm going to spend a lot of time on shifting the emphasis from process-oriented quality measures to the avoidance of low-value care. I'm going to spend a lot of time supporting that assertion. Number 4, we must standardize our data, obviously. COVID put a spotlight on this problem, but we already knew all about it, right? The past national emphasis on exchanging messages between EHRs must now be shifted to improving the quality and the standardization of data that's being exchanged. We must achieve comprehensive and persistent use of LOINC, RxNorm, and SNOMED in orders and results, then follow up with standardized patient cohorts and value sets around those patient types. That's the beginning of the data standardization journey. To be clear, I don't care who leads this change or how. I'm just trying to raise awareness, planting seeds of thought in hopes they grow. All right, now let's go into the supporting evidence behind these assertions. We're burning out our clinicians with data entry. So we need to stop this vicious feedback loop of clinician data entry burden, which feeds the dehumanizing measurement of those same clinicians. And that's the circle in the upper right. Data entry burden, we then measure them with that questionable data, and it further strips them of their sense of mission and purpose. So, as indicated in several studies, EHRs are contributing to burnout, and we're seeing the highest suicide rate of any profession among physicians, greater than 50% burnout in all specialties. For heaven's sakes, we have to change this, right? If for no other reason, the golden rule and a sense of empathy for what we're doing to physicians and nurses, who are some of the most mission-driven people in the world. We have to do better. Another article that came out in The Lancet in September 2019, The Empathy in the Age of Electronic Medical Record, from Danielle Orphery at NYU. Her quote was pretty powerful. There is at least one upside to this mess, however. The aggressiveness of the EMR's incursion into the doctor-patient relationship has forced us to declare our loyalties. Are we taking care of patients, or are we taking care of the EMR? The good news is, at a national level, thanks to those who contributed to the 21st Century's Cure Act, there's a focus now, there's a requirement at the federal level to reduce the effort and time required to record information in EHRs, reduce regulatory reporting, and improve the functionality and the intuitiveness of EHRs. And there are 4 work groups currently working on this, and I'm keeping my fingers crossed that Mickey, being the great professional and person that he is, will push this agenda forward very aggressively. Assertion number 2, we're using the wrong data. We need to shift our strategy to the data of population health, patient-specific care, and clinical research. Bill, credit to you for your long history in raising the awareness of this problem. This was a great paper describing how the data that we're collecting in EHRs is of questionable value and has some significant caveats related to comparative effectiveness research. So our awareness of this problem has been around for a long time, thanks to people like Bill and Nicole Weisskopf. Now it's time for us to actually do something about it. This is a great diagram from Bill's paper describing the relationship between central tenets of biomedical informatics and data-centric caveats pertaining to the design and the conduct of comparative research. And what I would say is, it's like navigating with GPS that's only accurate to within 20 miles. Patients deserve better precision in the data that we're using to make decisions about their lives. This is a great framework. So as we go forward with solving these problems, we have all of these great thinkers that have already put a lot of time and intellectual capacity into describing the problem. Now we have a place to start solving the problem, okay, thanks to these papers. This is a great paper that came out in July of 2019 from Toronto, Microsoft, Johns Hopkins, etc. Opportunities in Machine Learning for Healthcare. It's a great paper. If you haven't read it, I highly recommend it. It's super insightful. Diseases in EHRs are poorly labeled. Conditions can encompass multiple underlying endotypes, and healthy individuals are underrepresented. This article serves as a primer to illuminate these challenges and highlights opportunities for members of the machine learning community to contribute to healthcare. Back to my previous comment, we will never realize the full potential of AI and machine learning that other industries are leveraging if we don't do something to improve the breadth and depth and quality of the data that we are collecting in healthcare, and especially in EHRs. I would also point out that the text that we're collecting in clinical notes is questionable quality. Some of that is contributed by the cut and paste and the templates that are enabled by EHRs, but also a lot of it is frankly just because fee-for-service medicine drives volumes over quality. And when you're a clinician, it's a lot easier to cut and paste and move on to the next patient than it is to give, really thoughtful content to your progress notes and clinical notes. In a typical note, according to this JAMA article, 18% of the text was manually entered, 46% was copied, and 36% imported. So that's not precisely describing patients. And this is actually something that physicians could take care of on their own right now. If we could back off on fee-for-service volume-based medicine, that is. I do believe there's lots of opportunity for us to improve the standards and the principles around clinical notes. There's a lot of variation in clinical notes across the industry. Another interesting point in this JAMA article was that the documentation that's entered in an EHR does not equal the observed physician behavior. So this was a fascinating study that revealed 61% of the time, EHR data did not reflect reality in the review system. So they had an observer in the exam room looking at the interaction between the patient and the physician. Then that observer compared what they saw in the interaction with what was entered in the EHR. And there was a significant gap between what was recorded in the EHR and what the observer noted in the interaction. This is a great paper from your colleague Nicole Weiskopf. And it's the headline there, the paper describes it well. There's a significant bias in EHR data towards sick patients. Significant bias. So machine learning and AI are going to incorporate that bias. And this is a strong quote from the paper. These results should serve as a word of caution to researchers wishing to use EHR data for research. Investigators wishing to reuse EHR data must be aware that blind sampling of complete records within an EHR database may skew the sampled population towards sicker patients. And this is just a summary of the amount of data by ASA class of physical status classification of the patient for labs and medications. But this is a very deep, informative paper. Highly recommend everyone spend time on this paper if you're interested in the topic. So I would say, given that we are only really collecting most of our data on sick patients, what if the only time the airline, gas, and oil industry collected data about the health of their assets after a failure? We have to change our mindset to collecting data on all patients. Assertion number 3, we need to change our quality measure strategy, which will reduce the data entry burden and return professional autonomy and purpose to clinicians. This was a great paper that came out from some of the luminaries, some of the 20, 30-year advocates of quality measures in the industry. It came out about a year ago. And it was essentially a summary of what have we learned about quality measures in the industry over this many years, many decades, precipitated by the IOM study in the 90s. And here are a couple of quotes from the paper. And by the way, the paper essentially says, we're not doing well with quality measures. So this quote, what is primarily missing is not progress in measurement, but progress in results. Reading between the lines, we're over measuring and we're not seeing results. The second quote, therefore, the hope reflected in the founding of NQF, the developing, certifying, and using sound metrics of the quality of healthcare would drive fundamental improvement, remains largely unrequited. So we really have to step back, friends. Now is the time to step back and really rethink our quality measure strategy. It is not working, and it's creating an enormous burden on clinicians and administrative burden on the system. My favorite quote from this paper was this one. The old saw says, weighing a pig does not make it fatter. Inventing the thermometer does not change the temperature. And assessing the quality of care does not change the care. So what I'm suggesting is that we shift, and by the way, you also have to remember that the beginning of my healthcare career started at Intermountain, which was probably the pioneer in really embracing quality measures. Brent James was an enormously influential person on my career and my thinking. So I'm all about measuring. I'm all about improving. But what we're doing with most of our measures is really about evidence-based care and processes of care. We're asking docs, do more of this, which leads to overdiagnosis, overtreatment, and it equates to more data entry to prove they did. What I'm suggesting is that we shift to an easier topic with enormous value financially and in terms of health to patients. And we shift to low value care, where we're asking docs do less of this, which equates to less data entry. Because the absence of data about an order or procedure means they didn't do it. So not only are we shifting to more understandable quality measures in low value care, but we're also consequently removing a data entry burden from clinicians as a result. And I think we all know that, and there's plenty of evidence to suggest that a lot of our quality measures are clinically invalid. This was a great paper led by Catherine McLean and others that looked at 271 measures in the quality payment program. 86 of those were related to general internal medicine. So Catherine and team put together a panel to review those 86 measures, and they found that 37% were completely invalid clinically and 28% were of questionable validity. But yet we're still asking clinicians to collect data about those, and then we're measuring by those. And I can't think of anything that would be more disheartening if I were a clinician caught in that trap. I would also suggest that a lot of our emphasis on quality measures comes from a perspective of evidence-based standards of care, where we are telling physicians what they should do. But the truth is, by any number of studies, a significant portion of evidence-based standards are later reversed. In fact, this paper would suggest that 46% of standards of care were reversed. So the debate about what constitutes evidence-based care is constant and volatile. We're still learning about healthcare in the human body, but we're getting much better about understanding what we shouldn't do as opposed to what we should do. Here's another study, 396 medical reversals. Again, sponsored by a lot of the brilliant folks at Oregon Health Sciences University. Okay. Another study about low value care in the military health system, which was an interesting study because there are two economic models in the military health system. One is direct care, where there shouldn't be any economic incentives for over-treatment, and also purchase care. So in both economic models, there was too much care, low value care especially. Another study from Rand at University of Michigan also shows how the reduction of low value care equates to significant cost savings. So 44 low value care services were studied, $586 million in unnecessary direct costs over 5.5 million beneficiaries. Another study from Deloitte about how much we can save in the US, $210 billion a year in direct unnecessary costs per year from low value care. The CMS has done a pretty good job of defining low value care. It's a relatively small discussion. It's a relatively small number of things to debate, is what I would argue, as opposed to the discussion about evidence-based care. I think low value care provides a highly valuable, lower data entry approach to data collection in EHRs. Yet another article out of the folks at University of Washington about the use of best practice alerts in an EHR to reduce low value, high cost medication prescriptions, significant savings. So lots of evidence to move our quality measure strategy towards low value care. Assertion number 4 is we must standardize our data. And if accountants and retailers can do it, we can do it. So generally accepted accounting principles and UPC barcodes are really all about data governance, standard data collection, reporting, and analytics. Our entire financial industry in the US is based around generally accepted accounting principles. We put a lot of faith and trust that everyone is looking at data, collecting data, and reporting data in a very trustworthy way. Those standards in the financial industry and in the retail industry have innumerable downstream business and consumer benefits. We can easily borrow from these lessons learned in healthcare and move forward with a better approach to our data. This is an example of the data quality at a national level. A simple query against Health Catalyst Touchstone National Data Warehouse recently. Across 80 million patients, contains granular data from essentially every EHR vendor in the US. It was an analysis of COVID-related lab results from a subset of that 80 million. And we found that of 6 billion lab results, only 6% of those were harmonized to LOINC. And drilling further, in a field that should have had a cardinality of 4, it had a cardinality of over 750. So not only is it not well harmonized to a standard vocabulary, but there is enormous variability in what should be a low cardinality field. This was another report that came out from the Evidence Accelerator Task Force, in which we mashed 2 data sets together, essentially, to see what kind of overlap we had. So 629,000 patients where diagnosis in EHRs and diagnosis and claims were compared. And there were, of that 629,000, only 45,000 had a similar diagnosis in both sets. So there's something fundamentally wrong with what we're doing here, friends. A great paper from Nicole Weiskopf, again, amazing amount of work that she's done and studied in this area. This paper describes a great framework for assessing the data in EHRs for reuse. So we have the framework, we have all of the thought that's gone into this. Now it's a matter of implementing it at a national level. This is a great summary of that, a 3x3 matrix. I won't go into the details here, but comparing and describing in a very simple, understandable way what constitutes data quality in an EHR. Again, we have a framework here. We have a really good framework for getting started on improving data quality across the country. Okay, so part 3, what can we do? Here are a few ideas, but this is where I would really appreciate a lot of criticism and feedback to see whether what I'm saying here is of any validity, really, right? I don't want to waste time on concepts that are not valid and good for the country. So I would suggest that there's 3 parts to the data quality strategy. There's data quality at the front end, there's data quality at the middle, and there's data quality in the back end. So on the front end, of course, it's enforcing and governing standards and principles on the front end of data collection. Starting from the question, what data do we need to support population health, specific patient care, precision medicine, and clinical research? Following lessons learned from GAAP accounting principles, apply that to EHRs, including clinical notes. In the middle, we have to figure out how we're reconciling patient identity. It's fundamentally important. I'll talk a little bit more about that later. And then on the back end, we need tools to harmonize data that slip through the front end data quality check. You know, who do we care about? We need standard definitions for patient types and subtypes. Registries. What do we care about as it relates to those patients? We need standardized value sets for patient types and subtypes. It took us months at a national level to come up with a non-volatile definition of a COVID patient. And it took us even longer to come up with answers to what do we care about relative to those COVID patients. We need to turn those definitions around faster in the industry and then make them broadly available for reuse. A couple of thoughts on patient identifiers. I would suggest we should follow lessons learned from the management of internet domain names and retail UPC codes. That is, create centralized governance, but decentralized, commercialized implementation of national patient identifiers. Doesn't have to be mandated for everyone in the country, but I think it makes absolute sense to require a mandatory patient ID, unique patient ID for Medicare, Medicaid, and DoD VA patients. And they make it voluntary for other patients with an insurance premium and/or tax dividend for participating and having a unique ID. I have a feeling that there's a vast majority of the US population who would agree with this if they knew how important it was. There will always be folks who are concerned, and we should respect their concerns about government identity management. But I believe we could create a framework like this and we could get 70 to 80% of the population to participate. I believe we need generally accepted principles for clinical notes. You know, we see significant variation. I funded NLP and text analysis. I've been in the details of clinical notes for my 25 years in the industry. There's significant variation in clinical notes for the same patient scenarios. Principles are taught in med schools and the principles are somewhat outdated, but in the field, it's the wild, wild west. EHRs need to support better structure and content. We need to create economic incentives to drive data quality. So where economic incentives support attention to data quality, such as in the quality measures we have, EHR data quality is reasonably high around quality measures. You know how I feel about quality measures, that's a different topic. But we've created economic incentives around quality measures, so therefore the data that we collect in EHRs is pretty high in that regard. But we need new economic frameworks to make EHR data useful for a broader set of purposes beyond billing and reimbursement. And we need a concentrated public-private collaborative to address this situation. So now we need to start looking around and say, who's willing to pay for better data? What types of economic levers can we pull and are available, and who has them? Who has money that's willing to pay for improvements to EHR data, clinical outcomes, and clinical trials? We should look at value-based care arrangements that incentivize data beyond the quality measures that we have now. There are targeted incentives through MIPS and other commercial incentives that should pay for data quality. The public health requirements at CDC in the states, they suffer because of the poor data quality. We're wasting money because they don't have the good data they need. Certainly the FDA and the pharmaceutical and life sciences world benefits financially from better data quality. Grants at NIH, CMS conditions of participation, commercial payers. There's plenty of players in the economic world who should have an interest in incentivizing a new EHR data strategy for the country. So in closing, I would love if Lauren, if you can pop up the poll, friend, I would love, if we can't get the poll going, then maybe we have a conversation offline. But I would love for everyone's reflection on those questions. And I also want feedback on whether, you know, are my assertions accurate or not? Are they defendable or not? Is this an issue or not? Because as I mentioned, this is the first audience in which I plan on evangelizing these concepts. And if they're invalid, I certainly don't want to waste other people's time. And if they are valid, I'd like to strengthen the assertions and the arguments as much as I possibly can. Thank you.
Yes, Lauren. There we go. Okay.
There it is.
There it is.
Give me data.
Give me data.
This is a whole new process for me, Dale.
So I assume 1 is low and 5 is high.
Yes.
Or is it the other way around?
Yes. Thanks.
Yeah, thanks.
Do I get to vote?
Do I get to vote?
Probably, if it's offering it to you. You know, while people are voting, there are some comments in the chat box that, you know, you could scroll down and address if you'd like.
Yes, for sure.
Yes, for sure.
Getting some interesting feedback.
Some interesting feedback.
I end up being a little confused by that, but I'll do my best. Let's see here. I'm reading from John Lee. Hi, John.
Lee. Hi,
Any thoughts on directly?
thoughts on directly?
This better data doesn't create CPTs, at least not direct. Yeah, I think we have to change and move towards value-based care, right, friend, and get away from volume of care, which is why it's super important for CMS and the commercial payers to get on board with this and flex their economic incentives to move us towards value-based care. That said, you know, I still think we can make progress on the fundamental thesis of improving data quality and reducing clinician burden, even if we stayed in a fee-for-service model, especially if we shifted to a focus on low-value care as opposed to the ad nauseum emphasis that we have on processes of care.
While the voting is going on, I'm just curious if I can ask a question or.
Sure.
Sure.
What's the incentive? What's the incentive for insurance companies to, I mean, they use the medical record as a way of denying care in many cases. What's the incentive for them to make these changes?
Yeah, I think that's a great question, friend. I mean, the cynic in me would say there is no incentive, right? And we've seen that for years. The insurance companies keep passing on premium increases, right? And so quality of care, I would argue to the cynical side of me that insurance company doesn't matter much. On the other hand, I do think there is momentum among the insurance carriers towards a different view of that world. We cannot keep consuming the economy of the country with premium increases. That's one reason that Sarah is a welcome partner for me to carry this message forward, because I think the insurance companies have to play an active role in this. And by the way, I also think we have to bring on board the employers who are largely footing the bill for these premium increases. Yeah.
In terms of insurance companies, so what we see a lot is when there's an increased documentation burden, like say for example the SEP1 sepsis requirements that emergency providers have to do. I mean, what I've seen is hospitals will just hire a full-time person just to go over all of the documentation, go back and have clinicians remedy deficiencies. So I mean, they're still, you know, CMS uses that measure to deny payment, but in response, you know, hospitals are just hiring fleets of, you know, essentially clinicians to go and make sure they do get paid. So overall, you know, I don't know how much money CMS is really saving. They're just increasing the burden of cost to the healthcare system as a whole. So, I mean, eventually that seems like that's not going to help insurance companies when the cost, you know, everything is just more and more expensive. If they can pass everything on to, you know, individuals, maybe, but if they can't, they're going to lose out.
Yeah, I totally agree, Eric. And I mean, I think that's a good example of not just the emotional burden, but the administrative burden that these data collection requirements are putting on the system. Which again, I think that the federal government is in a great place to convene the insurance companies to participate in this, because it's killing the industry and it's killing clinicians, and it's, you know, eating away at the economy.
There's also a comment in the chat that I would make too from Dodge and about her comment is avoidance of low value care is certainly a noble goal, but can you comment on the U.S. cultural acceptability of restricting these practices, which is something I think about because oftentimes one person's unnecessary care is another part of the healthcare system's revenue stream, and sometimes it gets caught up in politics and so forth. So how do we drive home the which I completely agree with, aiming to get low value care out of the system. How do we make that happen, without some of the pushback we're likely to get?
Yeah, and a great point. I can remember years ago doing some consulting for one of the largest IDNs, and I suggested that we reduce some of these, and they immediately took it to the bottom line of their revenue and said we can't. It was lab tests. I would say that money talks, so I think we can create incentives, these shared risk incentives, where the reduction of low value care gives an incentive back to the organization for those reductions, right? It's sort of the inverse of what we're doing with margins on bundled payments, for example, where the cost savings associated with the reduction of low value care has a dividend back to the providers, right, in the pursuit of that. But yeah, I think that's really cheap.
So Dale, the conversation about low value care is part and parcel of your data issues, or the data arguments that you're making, because how do you define low value care? And it's much easier to define a successful colonoscopy or an arthroscopy with a CPT code and get paid for it. But then what is the definition of low value care? And then it gets into a very messy conundrum of, well, if you define it that way, let's use redundant. Actually, an excellent use case is actually the struggle that we're having with the appropriate use criteria in radiology. The workflows that are foisted upon providers to document whether a particular advanced imaging study is really, really cumbersome, and from my perspective has been a complete failure given the current construct of what we have available, and has added a huge amount of documentation burden on the ordering providers. And at the same time, the people who are benefiting from all this extra imaging is our radiologists, CT manufacturers. There's an entire ecosystem of people whose profit is the system's waste. So there, all of that contributes to a lot of the inertia that you're so eloquently describing.
Yeah, I agree, John, and I do recognize that being a weakness of my low value care argument, is that there are times when that low value care is actually appropriate care, right? And so you get into pre-authorization and justification and things like that. I would say it's a lesser of evils than the current approach that we have to measuring processes of care. I think it's a lesser of evils. I don't necessarily think it's perfect, but I just think it's simpler. For one thing, the definitions of low value care are actually pretty manageable in terms of their number and complexity. It's pretty easy for us to identify we shouldn't be doing this in general. So I think it's an easier argument, and again, kind of a lesser of evils. But I'm certainly open to other thoughts.
Just to be clear, I agree with you. I'm not trying to argue. I'm just talking about even though that it's relatively easy to define high or low value care, it's far easier to do this colonoscopy, flip the CPT code, and then get paid from that.
That's a good point. Yeah, really good point. Back to Dajin's comment, cultural acceptance of the concept. There's a lot of other comments here. Bill, do you want to moderate some of the comments here, friend?
Yeah. There's some comments there, which is something of interest to me as well, about, ways of extracting good data out of the text, because, as I've noted, and others as well, clinicians want to read and write the story, but the story oftentimes is challenging to get good, unambiguous data out of. And so a couple commenters have commented about the use of machine learning, AI kinds of techniques for extracting data out of the narrative. Could you comment on the use of the narrative and ways that we might process it to help us get good data? Because that's also the easiest way for clinicians to enter data, is just to tell the story.
Right. So yeah, I would love to do that actually. And now I'm going to lean on my NSA background, which was all about text data. There was some discrete metadata that we would look at, but most of the time it was either text or translated conversations that we were trying to make sense of. And I would say that I funded this kind of research, so I'm at fault with what I'm about to describe. I think we've been trying to pull discrete data elements out of clinical notes for far too long, and it's a very difficult problem to solve. Not to say we should stop doing it, but we need to spend a little bit more time on just pattern recognition of topics in text, as opposed to pulling discrete topics out. So let me describe how the NSA works, for example. You present the output of what, for the most part, it was neural nets. You present the output of pattern recognition in text to an intelligence analyst. That intelligence analyst looks at the patterns that are emerging in text, and they present their human interpretation of those patterns back to decision makers. Okay. What we, as opposed to trying to pull out, and I literally did this, like pulling out whether or not a terrorist was specifically going to attack at a point using these means, that kind of discrete knowledge in text is super, super hard to pull out. And it's even more complicated given the medical language that we deal with, right? It's one thing to do that with translated normal day-to-day language and text, but medical vocabulary is a completely different world. So I would advocate, all of us as informatics professionals, we need to start putting more emphasis on pattern recognition in text around topics that then we expose to what I've been calling a digitician, the modern version of a medical informaticist, expose that to a digitician who then presents that back to decision makers. And it could be that we present it back in a meaningful way to clinicians, but I actually think there's a role for these digiticians to serve as the intermediary data person between the clinician and the patient for interpretation. So that's one thought. The other thought is, and this is based on some work that we did at Northwestern. When I landed at Northwestern, we were in the early stages of deploying both Epic and Cerner. And I watched the utilization of clinical notes evolve in that deployment. And I saw a great variation. Some clinicians wanted to know this long, some clinicians wanted to know this long, even though the patient scenario was essentially the same. So I worked with David Leibovitz, dear friend, Gary Martin, others at Northwestern. We just said, hey, let's just put out a one-page general guidelines about how to get the most out of your EHR. We restricted it to one page. You could call it the first version of meaningful use. It was one page just in general. This is in principle how you should use an EHR. This is back in 2005, by the way, so 16 years ago. And we got general consensus from the clinicians to converge on principles around clinical notes that everyone agreed with in terms of breadth, content, brevity, that kind of thing. So it was super successful for us. The interesting thing was it fed better data into our NLP experiments. So I would love to see a more national effort on the part of physicians and nurses to do a better job around guidelines in clinical notes, because there's too much, in my opinion, there's way too much variability in what we're typing into EHRs right now. Oh, and John asked what I still have that one page document. Send it out. And there's a sad story there, actually. David Blumenthal and John Glasser got their hands on that document, and that was the seed that started meaningful use around EHRs. And we all know what meaningful use did.
I'm just looking, scrolling up and down the list, and I'll keep a copy of this and send it around. Dana Womack, another one of our faculty, asking about some of the things that are basic aspects of care that may have lower urgency. For example, oral care to prevent hospital-acquired pneumonia. I wouldn't actually necessarily think of that as low value care, but it may be lower urgency care and may get lost in the shuffle. And, you know, some of those things can be really important. So if I'm misquoting you, Dana, speak up. But I think this is an issue that sometimes we kind of lose track of the, you know, the things that are truly important. They may not seem big, and, you know, and we're trying to get rid of things that are expensive and so forth, that we lose sight of some of the simpler things.
Mm-hmm. I have a question. Well, never mind. Go ahead.
It was also a little related to the nomenclature too, because if you think of low value and people interpret that as low cost, you know, and some of these things that are discounted in nursing already and relegated to aides and drops when things get too busy, it's like we want to be careful not to discount those because they are very important.
Yeah, there's actually very high value, low cost care, isn't there? Back to oral exams and things. Yeah, that's an interesting thought. Maybe we need a list of low cost, high value care. That's an interesting thought. Huh.
Yeah, and actually a lot of the low value care can be high cost. I mean, you know, tests that we don't need that expose people to, you know, radiation or other kinds of harms. So I don't think of those sort of simple things as necessarily low value.
Mm-hmm.
So there are a few more comments in the chat box. I guess we're running up against the hour here. Lauren, did we ever get the results of the poll, or did that?
Let me see if I can share this.
Okay.
Burnout.
Lauren, if there's a way we can extract the chat so that I can spend some time thinking about afterwards, that would be super helpful too, friend.
Yeah, we'll capture everything. So I think we are just about at the hour. This has been a great conversation, and it's obviously something that requires a lot more than 1 hour to talk about. So I hope this is only a beginning, and you know, I hope we can continue to have this dialogue in the appropriate forum, and as this topic percolates itself up into the national conversation, we'll see what happens. So I want to thank Dale for sharing his thoughts with us, and everyone else for joining the conversation and participating. And we'll hopefully find a way to continue to keep this conversation going. So have a great day, everyone.
Many thanks to everyone. Have a great day. Bye-bye.